Hi everyone, welcome to POC Nurse. My name is Gozi, and in this video we're going to discuss Acute Respiratory Distress Syndrome, ARDS, for the CCRN exam. What is ARDS? It's a syndrome of acute respiratory failure, and it's characterized by non-cardiac pulmonary edema and also characterized by refractory hypoxemia. Now, this refractory hypoxemia is caused by a pulmonary shunt and intrapulmonary shunt. What does this shunt mean? This shunt is basically a situation where blood is flowing by the alveoli through the pulmonary capillaries, but there is no gas exchange occurring. That is the shunt that we have, and that is why the patient is hypoxemic. So for me, when I think about ARDS, I think about it as a disease affecting the alveoli and the pulmonary capillaries. So essentially, the capillaries get more permeable, they're releasing fluid filled with protein, and that fluid is finding its way into the alveoli, filling up the alveoli and leading to this really severe hypoxemia. For a patient to be diagnosed with ARDS, the patient has to hit certain criteria. So the criteria for defining or diagnosing ARDS as follows. First, it has to have an acute onset. So obviously the patient would be in some kind of respiratory failure, respiratory distress. It has to be of acute onset. More specifically, it has to happen within a week of a precipitating event or an insult to the lungs or to the body, because ARDS could be caused by direct injury in or to the lungs, or indirect injury to the lungs, meaning it could happen because something has happened inside or to the lungs, or something is happening elsewhere in the body that is now causing ARDS. So the timing of the precipitating factor for this ARDS is a criteria to define ARDS or diagnose ARDS. The second criteria that has to be met is that on chest x-ray, there has to be, like if you're looking at the x-ray, there needs to be total whiteout of both lungs. And the report should say bilateral opacities noted in the lungs. So this is the second criteria to define ARDS. The third is that the patient's PF ratio has to be less than or equal to 200 millimeters of mercury. What's the PF ratio? It's basically dividing the PaO2, which should be greater than 60 in a normal patient, dividing that number by the FiO2 the patient is getting, fraction of inspired oxygen, which room air is 21%. So for the patient with ARDS, the PF ratio should be less than or equal to 200 millimeters of mercury. Regardless of the amount of PEEP, the level of PEEP that the patient is getting. The fourth criteria is that when you measure the patient's pulmonary artery wedge pressure or the patient's pulmonary artery occlusive pressure, it should be less than or equal to 18 millimeters of mercury. What does this number tell us? It just tells us that the heart is functioning well and that the pulmonary edema that's occurring in this patient is not of cardiac origin. So ARDS, of course, is pulmonary edema, but to say the patient has ARDS, this pulmonary edema must not be caused by heart failure or anything of a cardiogenic nature. I want to quickly talk about alveolar cells. Because they contribute to the occurrence of ARDS. Now, the alveoli have two types of cells, type 1 alveolar cells and type 2 alveolar cells. So now, the type 1 alveolar cells contribute to the, it helps to maintain fluid in the capillaries and prevent the fluid from getting into the alveoli. So the type 1 alveolar cells, I'm trying to explain it in a way that's easier to understand. So the type 1 alveolar cells are connected to each other, and the connections they have with each other are tight. The reason for the tightness of these connections is to prevent infiltration of fluid from the capillaries into the alveoli. So they help prevent the alveoli from getting fluid filled due to the proximity that they have with the capillaries. I hope that makes sense. So the type 1 alveolar cells form an impermeable barrier that limits infiltration of fluid into the alveoli. In ARDS, these cells get destroyed. And because they get destroyed, permeability increases in the capillary membranes of the pulmonary capillaries. So then you get fluid, protein-filled fluid, moving from the capillaries and into the alveoli. This is how they get fluid filled. Secondly, the type 2 alveolar cells produce surfactant. What does this surfactant do? Surfactant reduces surface tension in the alveoli. So what does this do? To help myself understand surfactants better, this I read somewhere in a book or something, a definition that made more sense to me. Surfactant makes water more wet. And this makes sense to me because I know there are situations where water is not wet. For example, if you see an actual drop of water falling and staying together, it's because of increased surface tension. If that water had less surface tension, it will not stay together and pull together into a droplet, like a balloon that you see falling. Sometimes you look at leaves and you see droplets, balloons of water sitting on the leaves. Those balloons of water are able to form because of increased surface tension. So there are forces within that balloon of water pulling inward and maintaining that shape. So in the alveoli, the surfactant reduces that tension so that there is decreased atelectasis in the alveoli. So when we have surfactant, reduced surface tension in the alveoli stays open. When those type 2 alveolar cells get destroyed, such as in ARDS, this is what happens. The type 2 alveolar cells get destroyed. There is atelectasis occurring. So if a lot of these cells are getting destroyed or are destroyed in ARDS, then we have massive atelectasis. The alveoli are collapsed because there's increased surface tension now due to less surfactant, and the job of surfactant we know is to reduce surface tension. So in ARDS, there's reduced surfactant and increased permeability between the pulmonary capillaries and the alveoli. In the beginning of this video, we talked about potential causes of ARDS being direct or indirect. So things that could cause ARDS could be things that happen directly within or to the lungs, or things occurring elsewhere in the body. Direct causes of ARDS are chest trauma. Perhaps the patient has a pulmonary contusion. This could lead to ARDS. Aspiration pneumonitis could lead to ARDS. Pneumonia could cause ARDS. A fat or air embolism could lead to ARDS. Mere drowning could lead to ARDS. More direct causes of ARDS are hypervolemia or pulmonary edema, inhalation of toxic gases or vapors. So if a patient inhales smoke in a burning building or in a burning room, if a patient inhales corrosive substances, they could wind up having ARDS. Radiation pneumonitis, we spoke about PE earlier, particularly fat or amniotic fluid embolism, and some drugs could cause ARDS. drugs like bleomycin. Indirect injury that could cause ARDS are sepsis, which is the most likely causes that we see, hypovolemic shock, cardiogenic shock, neurogenic shock, or anaphylactic shock, multi-system trauma, especially when the patient has multiple fractures. When they have multiple fractures, they're more likely to have something like a fat embolism, a blood transfusion, burns. If the patient has cardiopulmonary bypass, that is CABG surgery, DIC, toxemia of pregnancy. If the patient has any kind of head injury that could lead to a central nervous system injury, a diabetic coma with ketoacidosis, acute pancreatitis, and drug overdose. If the patient overdoses on methadone, heroin, aspirin, thiazide diuretics, or barbiturates, the patient could wind up having ARDS. Signs and symptoms of ARDS. Before we talk about signs and symptoms of ARDS, I want to quickly talk about severity levels in ARDS. So ARDS could be mild, it could be moderate, it could be severe. When it's mild, it used to be referred to as acute lung injury. So in mild ARDS, the patient's PF ratio is less than 300 millimeters of mercury with a PEEP of 5 centimeters of water. In moderate ARDS, the patient's PF ratio is less than 200 millimeters of mercury with a PEEP of 5 centimeters of water. In severe ARDS, the patient's PF ratio is less than 100 millimeters of mercury with a PEEP of 5 centimeters of water or greater. So in all the severity levels, the PEEP could be 5 centimeters of water or greater. I don't want any confusion there because I think I almost confused myself even. Okay, now some other things that have been used to describe, some other terminology or words that have been used to describe ARDS are shock lung, pulmonary fat embolism syndrome, and the one I like best is alveolar capillary leak syndrome, because at the basis of ARDS, this is what's happening. The capillaries are leaking protein-filled fluid into the alveoli. Now, let's talk about signs and symptoms of ARDS. We have the early signs and the late signs. So early on, the patient will show some tachycardia. The patient might have some neurosymptoms like apprehension. The patient might be restless. The patient might have a little bit of some shortness of breath, respiratory alkalosis. If you auscultate the lungs, you might hear some crackles. And on chest x-ray, you might see the ground glass appearance, just like in COVID. And the patient's PaO2 on room air would be approximately 60 millimeters of mercury. So 60 millimeters of mercury is the lowest normal. So we start our interventions when the patient is lower than 60 millimeters of mercury, because remember when we talked about acute respiratory failure, we said the patient's PaO2 will be less than 60 millimeters of mercury. Now, some late symptoms of ARDS are tachycardia, some episodes of bradycardia. The patient could be agitated, that is a neurosymptom. The patient could be extremely short of breath, that is extreme dyspnea. The patient in this case might have respiratory and metabolic acidosis. The lungs on auscultation could have crackles, and patient could be wheezing. On chest x-ray, we see a total whiteout of both lungs, bilateral infiltrates on both lungs. And on room air, the patient's PaO2 would be approximately about 30 millimeters of mercury, and the patient will be displaying refractory hypoxemia despite increasing FiO2 supply. And that's another thing. When there are lots of questions on ARDS on the CCRN exam, always look out for that refractory hypoxemia, but make sure the patient is in ARDS before you select answers relating to ARDS, because pulmonary edema caused by a heart failure could mimic ARDS, could be initially refractory to, because they might frame the question in a way where they want you to really think, is this non-cardiac origin or cardiac origin? So you have to be sure that they're talking about ARDS when you spot that refractory hypoxemia on the test. So that's it for the signs and symptoms of ARDS. We're now going to talk about treatment of ARDS. So ARDS treatment is mostly supportive treatment, but for the CCRN, it's important to know the pulmonary stabilization strategies used in ARDS. So here we're talking about intubation with mechanical ventilation. This is almost always needed in patients with ARDS, and it helps with reducing the work of breathing and improving ventilation in the patient. Another strategy used here is PEEP. PEEP is usually 15 centimeters of water or greater in the patient with ARDS. We can use PEEP of 15 centimeters of water or greater in the patients with ARDS. But the thing is that PEEP can cause barotrauma. So we need to monitor the patient for barotrauma. We have to make sure that the patient's blood pressure is normal. That is, that there is no hypotension. And if there's any, we want to treat that so that we can maintain proper cardiac output for this patient. Secondly, we want to limit the plateau pressure in the patient's lungs to 30 centimeters of water or less. We want to also limit the amount of tidal volume that we are giving to this patient. Now, this could lead to hypercapnia, but in this case, it will be permissive hypercapnia because we don't want to put the patient at risk for volutrauma, because if you give the patient a lot of volume, you might cause trauma. Volutrauma meaning the lungs you could puncture the lungs with all of that volume. Same thing with the PEEP that we're talking about earlier. The increasing PEEP could cause barotrauma in the patient. So for your CCRN, you need to know that the patient with ARDS is almost always intubated with mechanical ventilation to reduce the patient's work of breathing and improve oxygenation. We need to know that we give the patient low tidal volumes so that we can prevent volutrauma. And in doing so, we may have to have a little bit of hypercapnia. And with hypercapnia comes a drop in pH. And for the patient in ARDS, according to my book, a 7.2 pH is, patients tend to tolerate a pH as low as 7.2. We also talked about maintaining a plateau pressure of 30 centimeters of water or less in these patients. So these are the strategies that you have to know for the CCRN exam. Now, we also have to use strategies that help stabilize cardiovascular function, which is we need to support the patient's blood pressure. To do this, we can use fluids, we can use vasopressors, and in a case where the patient's ARDS is due to septic shock, most likely we have to use vasopressors. We need to monitor the patient for any kind of arrhythmias or disorganized rhythms and treat that, because remember, we need to maintain proper cardiac output. And anytime there's a disorganized rhythm, arrhythmias, it throws off proper cardiac output. Prone positioning is another supportive management for the patient in ARDS. When you prone the patient, there's increased delivery of blood flow to underperfused areas of the lungs, and this would increase the ventilation/perfusion in the patients. It helps keep the alveolar lung units open, and this improves gas exchange and prevents further injury in the patient. Now, if the patient is intubated, we have to be careful so that we don't misplace or lose our airway. And we also have to be careful not to cause any kind of pressure injury from proning the patient. We need to monitor this patient for their acid-base balance, because remember, when the patient is acidotic, our pressors are not going to work. Some of our medications won't work, and these are important medications that we need to work. So we need to make sure that the patient's acid-base balance is within normal limits or acceptable. We need to implement strategies to prevent DVTs in the patient and prevent stress ulcers as well. Patient will require sedation and analgesia for pain. Patient will require nutritional support. Nitric oxide helps with improving oxygenation in the lungs, so the patient could get nitric oxide as well. The patient may go into organ failure, so we need to prevent that and identify that, and hopefully implement strategies that could help prevent that, such as maintaining cardiac output so that all of the patient's organs are getting adequately perfused. We could provide emotional support to the patient and the patient's family. We also need to monitor the patient for complications, which we'll talk about in a little bit. And according to the book, there should be no use of steroids. Now, this is what the book says. Real life is different, but to pass the exam, you have to answer with your book and not real life all the time. So according to the book, we should not use steroids for the patient in ARDS. Now, what are some complications of ARDS? Well, mortality is one, and mortality for ARDS is about 30%. The patient may not die from hypoxemia, but they could die from multiple organ dysfunction syndrome. Some other complications that result from ARDS are secondary infections, pulmonary embolus, a PE, skin breakdown that could get infected, alias, patient might not be getting enough nutrition, patient might be malnourished, and barotrauma could occur. So the patient could have a pneumothorax or subcutaneous emphysema. That is it for ARDS for the CCRN exam. This is where we're going to stop for this video. I hope you found it helpful. Please like, share, and subscribe, and I will see you in the next video. Bye-bye.